Hi guys, welcome back. The next topic we're studying is tuberculosis, and in a recent exam he said what is present in the cell wall of this bacteria that gives it this uncanny ability to survive inside the hostile environment of macrophages and giant cells. A couple of guys in the exam, when asked with respect to the virulence factor, very casually answered that as mycolic acid. You're aware that mycolic acid is the one which is responsible for giving the acid fast character to the bacteria, whereas what is present in the cell wall which is giving this bacteria that capability to handle that hostile environment of the security system, that hostile environment of the macrophages and the giant cells, is a product by the name of lam, and the full form of lab would be lipoarabinomannan. Well, the topic that we're studying at the moment is one of the topmost infectious causes of development of death. And this is not valid only for India, but Harrison says that this is a data that is valid on a worldwide basis. And the only 2 years when this was not happening was with respect to 2020 and 2021 when COVID-19 was at its peak. But once COVID has tamed down, or I would say COVID-19 has become much more milder, now, tuberculosis is back in action as the topmost infectious cause or development of death. It's a public health problem because the R naught value, meaning of the word R naught value is that one case will be infecting how many other people. Well, for tuberculosis, it is still 1.2, because of which it still persists to be a public health problem because one case would be infecting more than one person. We have to bring the value less than one so that it ceases to be a public health problem. Nowadays, the incidence of extrapulmonary tuberculosis has been higher as compared to that of pulmonary TB. So, a large number of questions in the previous years from medicine perspective have been on extrapulmonary TB. And one of the questions that was asked said that what is the most common site of extrapulmonary tuberculosis? Your answer would be given as lymph node involvement. That would be tuberculous lymphadenitis. And lots of time it can happen that, and you would have noticed this in your outpatient department as well, that when you ask the Indian patient, are you having cough? I'm not saying that you are suspecting TB. Just generally, when you ask an Indian patient, do you have cough? They literally cough on your face and tell you this is how I cough. And imagine, God forbid, if a person who's sputum positive for acid fast bacteria is coughing on you or on a healthcare worker, the TB bacteria can land on your tonsils. And once the tonsils will be seeded, then subsequently after a few days and then a couple of weeks, the cervical lymph nodes will become bigger and there could be development of tubercular lymphadenitis. In fact, if intervention is not done, these lymph nodes will burst and then the pus will escape into the tissue spaces of the neck, causing a development of cold abscess as well. So tubercular lymphadenitis is the leading site of extrapulmonary tuberculosis. And then in one of the recent exams, what he did was he did not have lymph node in the options. If lymph node is not in the options, the answer should be given as pleura. And the moment I say that, a lot of people just ping me and say, wait, what? I mean, pleura? So pleura is the covering of the lung. I mean, you are saying lungs are getting involved, and then you are saying that pleural TB is extrapulmonary TB. Yes, guys, that is how it is described. If it is parenchyma of the lung that is involved, we call it pulmonary TB. But if the covering of the lung is involved, then we don't call it pulmonary, we call it extrapulmonary tuberculosis. So pleura can be involved. Then a couple of other sites which can be involved would be genitourinary. Here we'll be talking about putty kidney, we'll be talking about sterile pyuria and acidic environment. And genitourinary TB is an important cause of development of infertility, where especially in a female patient, there can be seeding of the fallopian tubes or even of the endometrium. Then we'll talk about port spine as well. Bones can be involved, joints can be involved, and these joints can be damaged to the level that avascular necrosis can also set in. We'll talk about gibbous and port spine manifestations in the later part of this discussion. Over and above this, we'll also talk about tubercular meningitis. Though I have already spoken about tubercular meningitis in the neurology section, but I'll be providing some interesting inputs for tubercular meningitis where we have presence of rich focus, that would be dissemination of TB bacilli into the meninges, causing a cobweb coagulum. Extensive increase of proteins in the CSF is encountered in tubercular meningitis. Then even the peritoneum can be involved, and the involvement of the peritoneum will cause development of ascites. Traditionally, we read about peritoneal carcinomatosis by ovarian cancer and then a development of ascites. But today we're talking about peritoneal tuberculosis, and then this could result in development of ascites. And for diagnosis, we can either go for ascitic fluid analysis or we can go for peritoneal biopsy as well. On a comparison basis, if he says what is the best way for diagnosis of peritoneal TB or pleural TB, your first answer would be pleural biopsy / peritoneal biopsy, as the case may be given to you. I repeat that again. If it is pleural tuberculosis, obviously there would be pleural effusion. I can do a thoracocentesis, remove that fluid and send it to the lab for evaluation. Similarly, if it is peritoneal TB, I can send the ascitic fluid for a laboratory evaluation. But if in the exam I'm getting options between peritoneal biopsy and then a peritoneal fluid analysis, that is ascitic fluid analysis, you have to select peritoneal biopsy. Similarly, if it is pleural tuberculosis, you first select pleural biopsy followed by a pleural fluid evaluation to be sent to the lab for nucleic based CBNAT, that is cartridge based nucleic acid amplification technology. Then we can even have involvement of the pericardium. The involvement of pericardium I've spoken about even in the cardiology section, where tubercular pericarditis can develop in a relatively older patient, and this would cause initially a pleural rub. It would contribute to pericardial friction rub, which has to be differentiated from a pleural rub. The pleural rub is the one which is best heard in the phase of inspiration, but then pericardial friction rub is one that is heard even on breath holding as well. In fact, I'll just repeat my statement. Pleural rub and pericardial rub can appear, I mean, from the correct or sound perspective, they might appear to be the same. But how do you differentiate between whether what you are hearing is a pleural rub or whether you're hearing is a pericardial rub? Is that pleural rub is best heard in inspiration, but pericardial rub can be heard even on breath holding because the heart would still be beating. Plus, there would be ECG findings, and then this guy can develop a pericardial effusion, he can develop cardiac tamponade, and even if you give ATT, the disease will resolve, but it will resolve by causing calcification around the heart. So it can cause constrictive pericarditis, which we have talked about in cardiology, results in pericardial friction rub and pericardial shudder, and those auscultatory findings have been discussed during the course of discussion in cardiology. I'll be putting up a little bit more, I'll throw a little more light on that data in the subsequent part of the slide. The learning part for you guys is that the leading site for extrapulmonary TB is lymph nodes, if not given in option is pleura, and the data has been given here in descending order of importance. Next up is lymph node TB or tubercular lymphadenitis, and in the previous years they have asked what is the site of Gons focus for this case, and your answer would be given as tonsil. As I've explained to you earlier that this doctor who's sitting in his OPD is attending to a patient who, unknown to the doctor, is having a cavity in his lung and is coughing on the face of a doctor. You see, if somebody is sputum positive for acid-fast bacteria, has a big cavity in his lung, and he's going to be coughing on you, then the TB bacteria can land and seed the tonsils, and therefore the healthcare worker can be subsequently developing over the next couple of weeks a painless cervical lymphadenopathy. Most of the time, the lymph nodes that would be involved would be in the posterior triangle of the neck, and therefore there was also an image-based question in the exam where you can see a soft tissue swelling in the neck with respect to the posterior triangle. And where I'm putting the inferior arrow at the moment, this looks like to be a fistula tract because there's a lot of scarring which is present here. So this looks like to be an area where maybe the fistula tract would be present, because ultimately what's going to happen in this case is that the painless cervical lymphadenopathy, the lymph nodes will enlarge and they'll burst. And once the lymph nodes will enlarge and burst, then the pus will escape into the tissue spaces of the neck, resulting in development of a cold abscess. And this cold abscess can then erode through the skin and create a fistula tract. So even if the history was not given, I mean, there was no description of a healthcare worker or an individual being brought with painless cervical lymphadenopathy and this fluctuant swelling in the neck, just by looking at the fistula tract, the first differential diagnosis, I mean, you cannot see the fistula tract per se, but the local scarring that is present and per se with respect to the location of this what appears to be a fluctuant swelling, the first differential in a developing country should be kept as tubercular lymphadenitis. Well, for the diagnosis of this condition, there are two ways I can go ahead. One, I can go in for an FNAC, but lots of time FNAC can be inconclusive as well because the needle might miss the area where the granulomas are present. Or suppose if a person is HIV positive, then granulomas are anyway not present. Bacteria are very much present, but granulomas are not developing with respect to HIV positive patient. So then the diagnosis would be in a limbo because the pathologist will just say the word FNAC report is inconclusive. Please correlate clinically. So the test that you can be doing is a surgical excision biopsy on a comparison basis. If both are given in the MCQ and he says that what is the best way for diagnosis of suspected tubercular lymphadenitis, your answer would be given as, if he says best, answer is point number 2, but if he says what is to be done first, Then in your OPDs also, for patients who come to you with suspected tubercular lymphadenitis, the first thing that you write is an FNAC. But as I explained, if it is inconclusive or if the needle is missing that site where the granulomas are present, or granulomas themselves are not present because the person is HIV positive, then excretion lymph node biopsy will be having a higher diagnostic yield. Usually the group of the lymph nodes that would be involved would be the posterior cervical group of lymph nodes, and along with that the supraclavicular group of lymph nodes can also be enlarged. Now why that is important is because traditionally we read about left supraclavicular lymphadenopathy. You all in surgery would have read about Virchow's node. All of you read with respect to Troyer's sign. That's usually seen with the lung cancer, stomach cancer, and even testicular cancer, where left supraclavicular lymphadenopathy can be present, which I said is a Virchow's node or is referred to as Troiser, Troiser, not Trousseau's. Trousseau's is going to be with respect to tetany, but Troiser sign. So supraclavicular lymphadenopathy, traditionally for the left one, we read with respect to a malignancy, but today we talk about supraclavicular lymphadenopathy. Could be left, it could be right, even involved with tuberculosis as well. And ultimately the lymph node will become bigger and erode and would result in development of a cold abscess. He can also ask you regarding differential diagnosis of especially tubercular lymphadenitis. So one, malignancies, hematological malignancies have to be taken into consideration. So lymphomas would be one of them. Mostly it will be Hodgkin's lymphoma, and in lymphoma you will always notice that the lymph nodes will be having a rubbery consistency. In contrast, when it comes to tuberculosis, in TB, you will always notice that this would be a matted, M-A-T-T-E-D, matted consistency of lymph nodes. But when it comes to lymphoma, it would be rubbery consistency of lymph nodes. And along with that, lots of time in lymphoma, we also find that the pain occurs in the lymph nodes with respect to alcohol ingestion, though there is no plausible explanation that is described in the textbook for the same. Apart from this, metastatic carcinomas are anyway to be ruled out. So, we need to be very careful whenever we are dealing with the lymphadenopathy. The important metastatic carcinomas from Indian perspective could be laryngeal cancer, then could be lung cancer, it could be even intestinal malignancies that could metastasize to the neck. So, metastatic carcinoma has to be kept in differential diagnosis. The third important cause is, I would say, important from the exam perspective, mainly because of the fact that this would be having this peculiar name, that is Kikuchi disease. And most of the time in the MCQ, there can be comparison with this with Kimura's disease. So for Kikuchi disease, alphabet H is the one which I would like you to remember so that you can correlate this with pathology. That is, in Kikuchi's disease, there would be a presentation of a histiocytic. You see, that's the H alphabet that is to be remembered. It would be a histiocytic lymphadenitis that is developing. And how to remember this, all I can say is, like in Punjabi, we say ki hal hai. So ki hal hai is like ki, hal is H, and then is histiocytic involvement. And if you compare this with Kimura's disease, you will notice and read in pathology also that in Kimura's disease, immunoglobulin E level, that is inflammatory changes, are usually the ones which are present. So in Kimura's disease, it would be a fibro-inflammatory changes because immunoglobulin E is elevated. In Kimura's disease, we have usually associated eosinophilia. So because inflammatory cells are the ones, immunoglobulin E, eosinophils, they're always related with inflammation. So this is a fibro-inflammatory disorder of the lymph nodes, which is usually seen in Middle East, Southeast Asian males. I'll repeat the data once again. How to remember this information? Ki hale, that would be Kikuchi. So the ki would be for the Kikuchi word, and H would be for the histiocytic lymphadenitis that we're encountering. Necrotizing, it's basically a necrotizing histiocytic lymphadenitis. And Kimura's would be because of the association with the inflammatory cells. It's fibro-inflammatory disorder. And this has been usually found to be relatively more common in Southeast Asian males. So that's why the associations have to be remembered. And if they ask you what is the treatment for tubercular lymphadenitis, ATT has to be given. But if you will specifically ask in the exam what is the treatment for a cold abscess, then obviously you need to give anti-tubercular treatment. But along with this, the pus also has to be evacuated. Now, traditionally, whenever there's a swelling anywhere in the body and we have to, do a needle aspiration of that fluctuant swelling, we will put a needle into the swelling from the bottom. But here he says that do not put the needle into the swelling from the bottom, because then the chances of seeding of the tract, when you're putting a needle into the swelling from bottom, your needle is going from bottom upwards, then there's a tract that is being created and that could be seeded by the TB bacteria, because pus would be having live TB bacteria here. So the chances of fistula formation would be relatively higher. So he says instead of traditional surgical teaching, wherein any fluctuant swelling, you're supposed to put a needle from the dependent part. He says put a needle from the top, that is called as anti-gravity drainage. So you just need to remember that for tubercular lymphadenitis, it is standard anti-tubercular treatment. But if he specifies the word cold abscess, then answer would be given as ATT with anti-gravity drainage. We will now focus on pleural TB, and the obvious manifestation in this case would be a development of a pleural effusion. As you can see in the X-ray, there is a very clear-cut blunting of the costophrenic angle, and you can also notice the Ellis curve which is coming up here, which is also called as meniscus sign. So the costophrenic angle is the first one that would be obliterated, and then the cardiophrenic angle would be obliterated. So therefore pleural effusion is the usual manifestation for pleural TB. And this can be seen both with respect to, from the question's perspective, remember that pleural effusion can be seen both with primary TB and it can also be seen with post-primary TB. I'll explain to you in about let me say another 15 or 20 minutes or so what I mean by the word primary TB and what I mean by the word post-primary TB. Or post-primary TB is also referred to as secondary tuberculosis or reactivation tuberculosis. So these terms at the moment might sound a little troublesome for you, but in the later part of the discussion, I'll simplify these terminologies of primary and post-primary tuberculosis as well. The usual reason why patient will come to us in this case would be fever, evening rise of temperature, night sweats, weight loss. Evening rise of temperature with night sweats, that's very characteristic pickup points in the MCQ and suggestive of tuberculosis. Plus there would be cough also present, breathing difficulty can be present of a substantial level. The reason for this breathing difficulty would be that as the effusion will become bigger, it will press on the lung parenchyma, so the lung reserve of the person is getting affected. So dyspnea exertion could be developing and subsequently dyspnea at rest would also be present. And because we talk about inflammatory changes in the pleura, so pleuritic chest pain will develop. On physical examination, he will talk about stony dullness or dullness to percussion. Along with this, air entry would usually be reduced. Instead of writing reduced air entry, he might even say absent air entry, especially if the effusion is very large. Then instead of saying reduced air entry, he might even mention about an absent air entry in these patients. Therefore, what I'll do in this case would be a thoracocentesis. This would be an ultrasound guided thoracocentesis, and once I obtain the pleural fluid, I'll send it to the lab for analysis regarding proving that this is an extrapulmonary tuberculosis. So let's look at the manifestations that should be present to say that this is a pleural effusion caused by tuberculosis. Usually the fluid that would be present would be straw colored or would be hemorrhagic. The last time I've described straw word is straw color CSF for tubercular meningitis in the CNS section, and today I'm talking about straw color pleural fluid, or it can be hemorrhagic as well. So you need to remember anyway, every time you read about hemorrhagic synovial fluid, hemorrhagic pleural fluid, hemorrhagic pericardial fluid, the first differential that should always come in your mind would be tuberculosis. I repeat that again. Every time we read about hemorrhagic pleural effusion, hemorrhagic pleural effusion can be seen even with lung cancer. But first thing in an Indian exam for hemorrhagic pleural effusion is TB. Hemorrhagic pericardial effusion, again TB. And even if it says hemorrhagic synovial fluid, obviously trauma can cause it. But apart from trauma and coagulopathy, hemorrhagic synovial fluid was a question in the previous year exams. You have to answer that as again a possibility of tuberculosis. Now, because in this case there would be an exudate present. Because of the exudate perspective, fibrin would be present, so this fluid can clot on standing. The protein values in this case will be more than 0.5 times the value of the serum protein. So Light's criteria can be asked in the exam. I'm not going into Light's criteria because that is discussed in the pleural effusion segment. But yeah, this is an exudate and therefore the protein concentration would be elevated. The LDH values would also be elevated. Usually I'll just say it verbally, protein values more than 0.5 times the value of serum protein. LDH values more than 0.6 times the serum LDH value, or more than 0.5 for protein, more than 0.6 for LDH, or the Light's criteria, which tell us that this is exudative. As far as the sugar in the pleural fluid is concerned, it would either be normal or it can be low as well. Every time we read about low sugar in the CSF, this could be meningitis, it could be tubercular meningitis. Today we're talking about a low sugar, which could be occurring even with respect to pleural fluid at the moment. And apart from this, in some cases, the value can be normal as well. As far as the pH is concerned, in some cases it might be acidic as well. Most of the time the pH would be in the range of about 7.3. And as far as the cells are concerned, in the initial part, white blood cells are the ones which would obviously be increased in the early phases. If you have identified the disease early, then there would be predominance of neutrophils. But if the same patient is identified after a couple of weeks, it is relatively a later presentation, then lymphocytes would be the predominant cell population. I mean, that's the standard data, that in any acute inflammation, you first have neutrophils and then subsequently you have lymphocytosis. So just like I've told you in CNS that lymphocytosis in CSF in an Indian exam should always be thought of first as tubercular meningitis, today I'm saying lymphocytosis in the pleural fluid in an Indian exam, first differential should be thought of as extrapulmonary TB, that is pleural tuberculosis. Now, apart from this, supportive tests have to be done, and the supportive test would be ADA levels. A lot of these questions would mainly talk about ADA, that is adenosine deaminase levels, which are found to be elevated. This is a good test which is suggestive. It's not diagnostic, but yeah, adenosine deaminase levels, if they're elevated, are suggestive of presence of pleural tuberculosis. And if he says that what is the best way for diagnosis of this condition, then our answer would be given as a biopsy. The best way for diagnosis of pleural TB should be answered as needle biopsy of the pleura, and then this needle biopsy of the pleura will be sent to the laboratory for both the culture part as well as examinations for presence of documentation of granulomas, and that would be case-18 granulomas that would be found. So needle biopsy of the pleura per se is the best test for diagnosis of this condition. Do not answer ADA levels. I said ADA levels are suggestive, but I did not say they're confirmatory. So if he says what is the best way, answer is needle biopsy of the pleura is much more accurate as a test as compared to pleural fluid analysis. In pleural fluid analysis, what are the findings present? Well, the sugar values can be normal to low, proteins value would be increased, LDH values would be increased because it is inflammatory. That is why the fluid will tend to clot on standing. That's a universal data that every time there is an exudative effusion, it has to clot on standing. So the best way for diagnosis, I should be jotting it down here also, that if he says that what is the investigational choice for pleural tuberculosis, that the investigational choice for pleural tuberculosis should be answered as needle biopsy of the pleura, where we'll be able to demonstrate both granulomas. We can do a nucleic acid amplification technology as well, and therefore we'll be able to confirm our diagnosis. The treatment would obviously be antitubercular treatment, but in some cases there can be even a worse situation like this. I mean, traditionally we'll have a pleural effusion, it will become bigger, it can be a hemithorax developing, it can cause a tracheal shift to the contralateral side if the pleural effusion is relatively bigger. But over and above this, we have seen cases, especially in India, where we get development of tubercular empyema. Now, meaning of the word tubercular empyema would be pus in the pleural space. So for tubercular empyema, if he says what is the management that is to be done, then obviously ATT has to be done. But every time there is a empyema, we need to put in a chest tube also, no? So if he says tubercular empyema, just like I was saying cold abscess, there is pus accumulation. I mean, drugs have very poor, antimicrobial drugs have very limited penetration into wherever an abscess is present. So we need to evacuate the pus, and therefore surgical drainage would be required. The bad news for tubercular empyema is that it is associated with extensive scarring of the pleura, and because of the extensive damage to the pleura, though you have evacuated the pus, now the two layers of the pleura will stick to each other and there would be a pleural fibrosis which will result in development of restrictive lung disease. It would be an extraparenchymal restrictive lung disease manifestations that would be developing. The reason for that, I'll say again, is inflammatory damage to the two layers of the pleura. They stick to each other, resulting in pleural fibrosis and then a restrictive lung disease that will occur. And if that happens, then for management of this, we need to go in for surgery where a thoracotomy will be done. And the procedure that we need to do now is called as decortication. This decortication procedure means that all the adhesions that are developed between the two layers of the pleura need to be broken so that the extraparenchymal restrictive lung disease can be minimized, so the damage can be relatively lesser. So decortication basically means that the adhesions would be broken and we'll have to remove the thickened pleura as well. There are two things I said. One, I said that there are adhesions. So first we need to break those adhesions, separate those layers, and then subsequently there would be a removal of the thickened pleura for thickened visceral pleura in this particular case. So the most important thing that you need to understand from this particular discussion is that every time there is a pus accumulation somewhere, you need to evacuate the pus, because otherwise drugs tend to have a horrible penetration into wherever there is an abscess formation. What can be worse than this? Well, worst this can be that TB per se, wherever TB is present, healing process can be impacted, and therefore these patients can develop a bronchopleural fistula as well. And if there is a bronchopleural fistula, that means bronchi will be connected with pleura, that means air will be going into the pleural space as well. So this can result in another complication that is called as hydropneumothorax. So you can look at the bad things that I'm talking about, though the incidence of these have decreased nowadays because we are able to diagnose the disease early, we are able to treat effectively. But in earlier times, we used to get tubercular empyema, for which we had to put in a chest tube and then subsequently need to do a decortication procedure where the thickened pleura, which was like stuck, it had to be separated and then it had to be removed. So removal of the thickened visceral pleura. And in some cases, there used to be development of a bronchopleural fistula, which will cause the air to go into the pleural space and cause the development of hydropneumothorax. How do you pick up a hydropneumothorax? Very simple. You will notice that the interface of the air and fluid will be a vertical straight line. Like in pleural effusion, you were noticing that I was mentioning that there would be Ellis curve present. The fluid will tend to accumulate like this. So just for symbolic purposes, then I'll erase it. Like in pleural effusion, the area will be white, and you will notice a curvature present that's called as Ellis curve or meniscus sign, whereas here you will notice that it would be a straight line present. So every time they give you an x-ray and you are noticing that the area is white, all you need to check out is that is there a concavity present of Ellis curve, is there a blunting of CP angle? Yes, but there is no concavity here, it's a straight line. So you'll answer that as hydropneumothorax. So that's a, I would say, a less commonly seen complication, but still worth its weight in the MCQ. Next up is TB of the upper airways. This would be complication of advanced pulmonary tuberculosis. So, well, what can be involved? If the sputum is having live TB bacteria, then because the sputum would be coming via the larynx and the pharynx, so larynx and pharynx can also get secondarily involved. Even the epiglottis can get involved, and that can explain the development of hoarseness and voice in these patients and speech issues. Then genitourinary tuberculosis is one of the leading causes of development of infertility. Recently, NEET PG, they put up this question, which is very classical for genitourinary tuberculosis. That would be development of sterile pyuria. Well, because there is an infection, there would be pus in the urine. But why the word sterile is there is because you are not using traditional LJ media for culture. I mean, you are not suspecting. Person came with symptoms suggestive of UTI. So the routine culture techniques will be used. Routine culture techniques, like even if you use McConkey's media can isolate coliforms only. It cannot isolate Mycobacterium tuberculosis. So the urine will turn out to be sterile primarily because of the fact that appropriate culture medias are not being used. But then at the same time, there would be pus cells in the urine. So remember, this statement was a one-liner MCQ in NEET PG 23 as well. Sterile pyuria in an acidic urine would be suggestive of, the answer would be genitourinary tuberculosis. There would be non-specific symptoms in a sense that traditional UTI symptoms would be present. UTI symptoms would mean like there could be increased frequency of urination, there can be dysuria, there can be nocturia, there can be hematuria present, but at the same time, the culture will turn out to be sterile. Those symptoms of UTI would be present. So what you need to do in this particular case is that you will be taking 3 morning urine specimens, consecutive urine specimens in this person. That is when the peak shedding is occurring, and the 3 morning urine specimens, which would be evaluated here or will be collected here, will be sent in for culture, and then we'll be able to isolate. I mean, appropriate culture techniques will be used. Lots of time the diagnosis is made when the damage is already done. As you can see in this image, you can notice the calcification in the kidney, and therefore he can just give this x-ray as a spot evaluation, and your answer would be given as a putty kidney, and therefore renal function can be hampered in this case. Like one kidney is affected, so the KFT this person can be subsequently deranged. And because of the fact that there can be ureteric strictures, like one kidney, there can be putty kidney, the other kidney is also involved, and there is a ureteric stricture developing, so there can be contralateral hydronephrosis as well. So bilateral renal involvement can be occurring in these patients as well. From the gender perspective, from a female patient, because I said it is one of the leading causes of development of infertility. So this is again a question that is discussed in gynecology as well, that what is the common site of seeding? That would be fallopian tube, and because the fallopian tube would be then developing adhesions with the adjoining viscera, so there would be kinking of the course of the tube, and that adhesions with the fallopian tubes and kinking of the course of the fallopian tubes can interfere with the subsequent motility of the ova, and as a result of this, infertility can set in. Even endometrium can get involved, so we might have to do a curettage, and then the sample would be sent for evaluation and culture would be performed in it. If it is a male patient, Then in genitourinary tuberculosis, usually the part that would be involved is epididymis, and most of the time the person will present with a tender mass. I mean, this would be with respect to the scrotum, a tender mass, and this tender mass will then drain it via fistulous tract. So there would be a fistulous opening just related to the scrotum in this person, and this was previously a tender mass that had drained subsequently. So epididymis can be involved. Then it can even cause development of arthritis. It can even cause involvement of prostatitis. But the minimum carry-home message from the genitourinary tuberculosis will be my first statement: sterile pyuria in a acidic urine, and there would be symptoms of UTI. I mean, the features are very much present. Symptoms of UTI are present, that is pyuria, dysuria, nocturia, hematuria is present, but then the culture is not yielding anything. That is when you suspect possibility of genitourinary TB, and in some cases diagnosis may be made after the damage has already become irreversible, or I mean, you may not be able to do much to salvage the damaged kidneys. Next up is skeletal tuberculosis, and usually the part that is involved is the spine, which would be referred to as Pott's spine or Pott's disease. Apart from this, the weight-bearing joints of the body, like the hip joint and the knee joint, can also be involved asymmetrically. Now, how will the spine get involved or the joints will get involved? Most of the time for the spine, it would be a occult dissemination via the lungs. It will go by the bloodstream to the lymph nodes of the paravertebral area. The paravertebral lymph nodes will become bigger, bigger, bigger. They'll burst, and then they'll disseminate this tubercular bacilli in adjacent vicinity of the vertebra. So the TB bacteria would be causing local destruction to the blood vessels. They'll be causing damage to the blood supply of the vertebral arch, the damage to the vascular pedicle, the damage to the blood supply of the body of the vertebra, and therefore the vertebral body will collapse. So meaning of the word Pott's disease or Pott's spine, as it is called, would mean that at least two or more than two adjacent vertebra are getting damaged. Most of the time, the vertebra body which are damaged or the vertebra that are affected would be lower thoracic spine with respect to adults and upper thoracic spine with respect to children. But the minimum that you were expected to remember at this moment would be that at least two adjacent vertebral bodies are getting affected. Because of this, the intervertebral spaces will also be hampered, and the total height of the person will also be affected, and there would be a deformity that would also be developing. That would be kyphosis that you're noticing in the spine, and I'm very sure you are aware of this deformity from your orthopedics class as well. This deformity is what is referred to as gibbous. This is not to be confused with what you read as Dowager hump. That Dowager hump that you come across is with respect to osteoarthritis of the spine. And well, guys, in orthopedics, you would have noticed that in osteoarthritis, there is a uniform reduction in the joint spaces. I mean, when you're checking out the x-ray, no, in osteoarthritis that involves the spine, there would be uniform reduction in the joint spaces. Whereas when it comes to tuberculosis, it would be a focal area of at least two adjacent vertebral bodies that would be destroyed. The blood supply of these vertebra is getting, because TB can cause endarteritis. Tuberculosis can damage the terminal blood vessels as well. So the local damage will anyway occur. There would be pus also developing here. The pus will also press on the nerve roots which are coming out of the spinal cord. It can cause a development of an epidural abscess which will press on the spinal cord, and therefore a devastating complication that can occur is in the form of paraparesis or paraplegia. As I've explained to you, if he says what is the most common site for Pott's disease, first I'm telling you spine gets involved more than the joints. Then I'm telling you that in the spine per se, the most common site would be answered as the lower thoracic vertebra. This is in contrast to upper thoracic vertebra. In pediatric age group, it is lower thoracic vertebra or the upper lumbar vertebra which are affected in adults. We'll do this repetition once again. Which is the most common site involved in adults? I'm writing only for adults. I'm saying that for pediatrics, if they ask you, answer that as upper thoracic vertebra. I'm not writing that down because we need to focus on the adult population. It is lower thoracic vertebra / upper lumbar vertebra, and this could result in a devastating paraparesis and then a paraplegia. And if it is paraparesis, if patient presents early, we can still plan a surgical decompression. But if it has been present for weeks, as usually is the case, irreversible damage would have occurred to the blood supply, the spinal cord as well. So neurological recovery chances in these patients would be relatively lesser. There is collapse of the vertebral bodies that results in development of a gibbous, as I've shown. And in some cases, we might even be having a development of a paravertebral abscess. This paravertebral abscess, the pus will track due to gravity inferiorly, and then might manifest in the form of a psoas abscess as well. So, well, these are the manifestations that we see with respect to skeletal tuberculosis, spine, and the joint involvement is what I mentioned. From the imaging perspective, I can either be doing an MRI of the spine or of the joints, or instead of MRI, if the facility is not available, I can be using a CT as well. If he says what is the best way for diagnosis, the best way for diagnosis would be a bone biopsy. I mean, if I can get a biopsy from the local damage, MRI guided, CT guided, that would be the best way for diagnosis. If bone biopsy is not possible and there is a paravertebral abscess or a psoas abscess, then we can go in for an aspiration of the abscess as well, which will give us indirect evidence for the presence of, on a comparison basis. I mean, first answer will be bone biopsy. If not given, then answer would be aspiration of the abscess. If he specifically mentions regarding the joints per se, then your answer would be a synovial biopsy. You will notice a pattern coming up here. When I was saying pleural TB, I did sensitize you to this in the beginning of the video itself. If it is pleural TB, pleural biopsy, peritoneal TB, peritoneal biopsy. Similarly here, if it's bone getting involved, vertebral body, so bone biopsy, then synovial biopsy and tissue culture is the best way for diagnosis in case it is the involvement of the joints per se. And this is the data that you need to remember specifically. If it is going to be a symmetrical reduction in the joint spaces in an x-ray given to you in a 60-70-year-old man, all the joint spaces are becoming lesser, person is developing a hump, that is a Dowager hump that you encounter in osteoarthritis, that would again be a kyphosis. But if it's going to be skeletal TB, then it's going to be mainly focal areas of joint reduction with at least two vertebral bodies getting destroyed. And as a result of it, the subsequent healing processes that occur in the body would result in formation of a gibbous. Next up is all familiar tubercular meningitis, and most of the time this would be via the rich focus. So tubercular meningitis, it's rich focus which is to be remembered. In MCQs it is saying rich focus, he might love to hear regarding the rupture of the subependymal. I mean, there's a seeding of the subependymal area by the TB bacteria initially, and then there is formation of these tubercles in this area, and then these tubercles will burst. So there's a rupture of the subependymal tubercles into the subarachnoid space, which will cause dissemination of bacteria, and this will cause like a chain reaction because the body or the immune system will react to it, and therefore the local damage or the fighting that occurs between the security system and the TB bacteria will result in inflammatory changes, and that is when the meninges signs will start evolving in this person. Most of the time the evolution of tubercular meningitis will be spanning a couple of weeks. For the clinical description of tubercular meningitis, the case-based discussion that has come, I would like you to listen to the CNS section. But at this moment, I would like to add on to the fact that TB pus can result in development of local manifestations that would be in the form of cranial nerve palsies. So traditionally in raised ICP, we anyway have 6 nerve palsy, but over and above 6 nerve palsy, other cranial nerve palsies can be seen in tubercular meningitis because of the pus which is present, which is thick, and due to gravity will go to the base of the brain, and base of the brain is where the cranial nerves would be originating, so cranial nerve palsies can be present. Then focal deficits can be occurring because TB causes end arteritis. I explained that earlier also. TB has a tendency to cause involvement of the small blood vessels, so the brain can get affected, so end arteritis, and therefore stroke-like manifestations will occur. So you will notice, like in tubercular meningitis, the child who is in altered sensorium now, mother might be saying one half of the body is not working. Hemiplegia could be described, like in port spine I was describing regarding paraplegia. Hemiplegia or arm weakness could be described in a question with respect to tubercular meningitis. The reason for that hemiplegia, the reason for that arm weakness is primarily the end arteritis component, which can damage the blood supply. Like, you know, if the area 4 of the brain, which is supplied by middle cerebral artery, M4 segment, M3 segment, those branches of the M3 and M4 are getting affected. So therefore area 4, that's the motor cortex, is getting affected. That's why the focal neurological deficit would be occurring. Plus because the pus in tubercular meningitis is very thick, so it will obstruct the flow of CSF, and that will cause hydrocephalus, so ventricular distension would be occurring. Now for the diagnosis of these cases, you will have to do a lumbar puncture, and you will be able to demonstrate presence of lymphocytosis. Lymphocytosis in an Indian exam should always be considered as tubercular meningitis, and along with that CSF sugar should be low. If CSF sugar is turning out to be normal, then you have to think in terms of viral meningitis, but if it is CSF sugar is low, that is suggestive of tubercular meningitis. Then the values of protein in the CSF of these patients will be substantially elevated. The values would be anywhere in the range of about 100 milligram to 800 milligram, which could be written as 1 to 8 grams per liter. Normally, the protein in CSF is only 15 to 45 milligram. From 15 to 45, let's take an average of 30, it would be increased to 100 to 800 milligram. And as a result of it, this will tend to clot on standing and could also result in formation of cobweb coagulum. The image of cobweb coagulum, which has been asked in the exam in the previous years, has been discussed in the CNS section. Now for diagnosis of this condition, though it's very, very clear, if he says what is the best way for diagnosis, then culture of the CSF is the gold standard, by which I'll be able to prove that, okay, I'm dealing with tubercular meningitis, but this is a gold standard technique. What we'll do nowadays is that we can go in for nucleic acid amplification technology. So what we'll do in this case is a CSF NAT that would be expert. That would be a gene expert test that I'm talking about to demonstrate Mycobacterium tuberculosis, and also if there is a resistance to rifampicin. So you can catch, I mean, in some MCQs it might be written as PCR of the CSF or Mycobacterium tuberculosis, or in some MCQs instead of writing the traditional way of PCR, he might write that test, that is CSF expert Mycobacterium tuberculosis, which also demonstrates rifampicin resistance. Then for the management of tubercular meningitis, obviously we need to give steroids, but along with steroids, it is also recommended to use, ATT anyway has to be given. That's the traditional data, but we will also have to give steroids to these patients. That is dexamethasone or prednisolone has to be given for a duration of 6 weeks with a taper. The reason for giving steroids is to thin out the consistency of pus, because pus in tubercular meningitis is very thick, so it will block foramen Olushka, Magendie, and it will result in obstructive hydrocephalus, and I want to minimize those chances, and therefore we need to give steroids to these patients. So steroids are currently not recommended for pleural tuberculosis and pericardial TB. I repeat my statement. Steroids are currently not recommended for pleural tuberculosis and pericardial tuberculosis. In earlier time, they were given even in pleural as well as in pericardial, but now steroids are recommended only with respect to tubercular meningitis. It would be a duration of about 6 to 8 weeks, and the tapering of steroids would be done. Reason for taper is preventing the risk of development of Addisonian crisis in a patient. And then another feature that must be remembered is tuberculoma. Tuberculoma is a small lesion that will be developing because of tuberculosis and can be a differential diagnosis for neurocysticercosis, because it's a space occupying lesion, and it can be more than one as well. So you could easily confuse this with neurocysticercosis. So what test will come in handy? The test that will come in handy would be MR spectroscopy. Again, for MR spectroscopy, I would like you to listen to neurocysticercosis component in neurology, where I've described that magnetic resonance spectroscopy will be showing a amino acid peak. For neurocysticercosis, the metabolism will reveal, MRS picks up local metabolism. So MRS in neurocysticercosis will show a amino acid peak, whereas with respect to MRS, it will be showing a lipid peak. So MRS is a good way to differentiate between tuberculoma and neurocysticercosis. Otherwise, in neurocysticercosis, there would be eccentric scolex present, and along with that, obviously, the history part also has to be taken into consideration. Then we can also do lumbar puncture and evaluate for neurocysticercosis antigens and antibodies, which will turn out to be negative if it's going to be a case of tubercular meningitis. If you want to learn more about tubercular meningitis, very important topic, always asked in the exam, always every year there will be a question on tubercular meningitis, whether NEET PG, whether ED SET, whether it's FMG exam. So I would like you, after you finish this video, go back to the CNS component and focus on the findings of tubercular meningitis that I've explained. Otherwise, from the perspective of extrapulmonary TB, in the end, I can talk about GI tuberculosis. The commonest site that is involved is the ileum. In earlier times, it was mainly bovine tuberculosis, Mycobacterium bovis, because you see, especially due to non-pasteurized milk being consumed in India, non-pasteurized milk will contribute to bovine strain coming into human beings, and thereby manifestations will occur. But nowadays, we get it not only with Mycobacterium bovis, but we can get it with the standard Mycobacterium tuberculosis as well. The reason for that being, like, if somebody is sputum positive, so when he will swallow, you see, sputum is positive for TB bacteria. When he will swallow, the TB bacteria will go in the GI tract also and can cause seeding of the ileum. And therefore, because of the stricture in the ileum, subacute intestinal obstruction can develop in these patients. And sometimes there could be a barium meal follow-through finding also described for these patients. That was obtuse. That was a question that I came across. Obtuse ileocecal angle would be seen in. So the answer should not be given as Crohn's disease. Obtuse ileocecal angle or junction would be a feature of tubercular involvement of the terminal ileum because of the local fibrosis that is seen, the stricture formation that is seen, which could result in features of subacute interstitial obstruction as well. Then there can even be a development of tubercular peritonitis. For diagnosis of tubercular peritonitis, as I've explained to you, the best test recommended would be a peritoneal biopsy. Though if I'm not having a peritoneal biopsy available, then obviously I can be going ahead with a ascitic fluid analysis, and this ascitic fluid would then be sent to the laboratory to evaluate for nucleic acid amplification technology, that is expert MTP RIF. Peritoneal biopsy will reveal granulomas and will reveal bacteria. That is okay, but like I said, if it's not available, then ascitic fluid analysis has to be done. For pericardial tuberculosis, the standard manifestations would be first a pericarditis, then a pericardial effusion, then a tamponade. And apart from the pericardial effusion component, even if you diagnose this condition and treat this patient, when you treat TB, the features of TB will resolve. But the bad news is that there would be a calcification developing around the heart, and this calcification that will develop would cause encasement around the heart and result in development of constrictive pericarditis. The learning point is constrictive pericarditis is a sequelae of tubercular pericarditis. When you treated this chap of tubercular pericardial effusion with antitubercular treatment for a particular duration of 6 months, and still the person is coming back to you, why? Because now he's ended up with calcification outside the heart. So because of calcification, the compliance outside the heart will be reduced, and as a result of it, Kussmaul sign would be coming up. Those auscultatory findings of pericardial shudder, pericardial knock would be described in a question. So more details for constrictive pericarditis are present in the cardiovascular section, and I would like you to go through that. And recent studies have shown that there is no role of steroids currently. In earlier times, there was steroids that were recommended, but now he says that there is no role of steroids for pericardial tuberculosis. You see, we wanted to minimize the calcification, but the recent meta-analysis that has come, he has said that there is no role of steroids and standard antitubercular treatment would suffice. Next, a few miscellaneous facts before we start with pulmonary tuberculosis. Adrenal gland can be affected by TB, and that can result in development of Addison disease. Traditionally, we read about Addison disease due to autoimmune destruction, but today we're discussing Addison disease due to tuberculosis as well. Then Osama bin Laden was suspected to be suffering from Addison disease due to tuberculosis. I mean TB adrenalitis. That was dissemination, subsequently occult dissemination via the lungs. Then he can ask about congenital TB also. The question that was asked on congenital TB would be that where will the child develop the focus in his lungs? So the child will develop the focus in the lungs in his liver. Well, the fetal liver is the one which would be involved in this particular case. Why? Because ultimately the baby gets oxygen from the placenta via the umbilical vessels, and ultimately all the oxygen goes into the body of the child with help of ligamentum venosum. So along with oxygen, it is TB bacteria that can be exhibiting a transplacental spread. In fact, look at the surprising data that I'm saying. I'm saying there can be a transplacental spread of TB bacteria which could go via the ligamentum venosum into the liver of the child, and the liver of the child gets affected. I mean, the question was mentioned as what is the initial organ that can be affected? So it's the liver of the child can be affected. Even the lungs of the child would be affected because of breathing of amniotic fluid which is contaminated with TB bacteria. Imagine TB bacteria which are going to be present in the amniotic fluid, and the baby is going to breathe that amniotic fluid, so it's going to go in the lungs. But on a comparison basis, if he says lungs and liver, the first thing that would be affected would be that the baby would be getting seeding via the placental circulation directly via ligamentum venosum into his liver, and then subsequently the lungs of the child would also get affected. In cases of TB, you will also read about a fungal ball. Most of the time, it's a late complication that we read, that once the TB has been treated or it's in the process of treatment, these patients can get infected with or they can develop a fungal ball in the cavity. The growth of fungus in the cavity, usually the fungus that is incriminated here is Aspergillus fumigatus. So it's just the name of the fungus that I wanted you to remember, because these fungal balls are relatively difficult to manage or difficult to treat, and in some cases they might even be life-threatening hemoptysis developing in these cases, because the cavity is anyway there. It would be adjacent to blood vessels, plus there's a fungus also present which is documented to be angioinvasive, and therefore hemoptysis could be occurring. Though I mean initially this guy was treated with tuberculosis, but the cavity that was present in the lung, that was a area of destruction that subsequently got seeded with a fungus, and that caused local damage. So this fungal ball with Aspergillus fumigatus is used most of the time, gonna be a late complication that can be seen with pulmonary tuberculosis, apart from development of bronchiectasis as well. So these are details for the extra pulmonary part, and now we will be focusing on the pulmonary tuberculosis part per se, where I'll be dividing the discussion into two parts: primary TB and post-primary TB. I would now like you to stop looking at the notes and just answer me a question without having a look at the notes. If a TB patient is coughing on you and the TB bacteria can land in your lungs, and let me just mark out three areas in the lungs. One is the apex, two can be taken as lower part of the upper lobe or somewhat upper part of the middle lobe, and three is the lower lobe. So where do you think, don't look at the notes, right? Where do you think that the TB bacteria will usually land? What will be the usual site of involvement of primary tuberculosis? Options are apex, then is like middle lobe, upper part, and then lower lobe. Well, you see, guys, usually when I put up this question, I get standard responses in the form of a apex, though you may not have given that answer. You see, apex, guys, is a site of reactivation of TB. It is a site for secondary tuberculosis. It is a site for post-primary TB. Listen to the words very carefully. Apex is not the site for primary TB. It is post-primary tuberculosis. It is a site for secondary tuberculosis. It is a site for reactivation. If these terms are sounding difficult at the moment, I'll simplify them before you in about next couple of minutes. My question to you guys was, if a TB patient who's a known case of, he's having a cavity in his lungs, he's having a big cavity, he's sputum positive for acid fast bacteria positive, I mean his blood, his sputum report says sputum for AFP++. If he's going to be coughing on you and you get this lung infection, unfortunately, though your immune system will be able to handle it, is site of primary TB. The most common site of primary TB should be answered as either the lower part of the upper lobe or it would be the upper part of the middle lobe. These are the usual sites. After the lower part of the upper lobe or upper part of the middle lobe, the next site that is involved is point number 3. Yes, guys, lower lobe involvement is more common with primary TB. Lower lobe involvement is more common. That's how the airflow is directed. The lower lobe, the TB bacteria will land most of the time into our middle lobe on the right lung and in the lower part of the upper lobe in the left lung, and then will tend to flow into our lower lobes as well. So it is the middle in the right and the lower lobe on the right, on the left side, which are the ones which are the usual ones that are involved in primary TB. And apex should be answered as primarily a site for post-primary TB or reactivation. Let me make it much more simpler for you. Let's now focus on what do you mean by the word primary TB? What do you mean by the word post-primary TB? So you just need to be patient and listen to the subsequent part of the discussion to get a better understanding here. So what's going to happen here is that, like, this patient coughed on me and the TB bacteria have landed in either the lower part of the upper lobe or maybe the upper part of the middle lobe. And once there is an infection anywhere in the body, then the body will react to this local damage by development of lymphangitis. So what I'm showing in the wavy lines here is lymphangitis, and I'm also showing a hilar lymphadenopathy. I mean, I'll show x-rays for the enlarged lymph nodes in a while, but at the moment, the point is that this initial seeding that I showed before you in the lower part of the upper lobe or upper part of the middle lobe is called as Gons focus. Earlier, I taught you Gons focus for tonsil, but now I'm showing you the site of Gons focus for primary tuberculosis. And the wavy line is the lymphangitis and the hilar lymphadenopathy. Now, during my internship, I was exposed to tuberculosis, but I did not suffer from TB because I had was a good immunity. But subsequently, to my surprise, when I had completed my internship and I had applied for a job where a medical checkup was required, when I got my x-ray done, my x-ray started showing multiple spots of calcification. You see, this is the same enlarged lymph node. This is the initial focus that I've shown. It is the lymphangitis. But then the body will try to prevent the spread of this bacteria, and the body will try to kill this bacteria and will limit the spread of this bacteria by development of calcification around the focus and the calcification around the lymph node. And that is why I said that, when I applied for a job subsequently where a medical checkup was done, to my surprise, I was having multiple calcified nodules in my lungs. And when I decided to find out why had I suffered from this, my consultant told me that you probably would have been exposed to TB, but because you had was good immunity, that is why this calcification prevented the spread of the disease and your immune system was able to limit the infection. And well, I did not suffer from pulmonary tuberculosis. So this description that I given you at this moment on this slide is what is technically called as Ranke's complex. Ranke's complex basically means a calcification around the focus as well as around the hilar lymph node to prevent the spread of the disease, and this would be seen in majority of cases. So not everybody who's exposed to TB will end up with manifestations of a cavity in a lung. Majority of people with a good immunity will be able to limit the infection. Now I will change the scenario and say that an adult is coughing on a child. You see, if adult is coughing on a child, per se, the per unit volume of the lung, the bacterial load exposed would be much more higher. You see, if an adult is coughing on an adult, your and my lungs are relatively bigger, child's lungs are relatively small. So if I'm TB and I'm coughing, I have TB, I'm coughing on a child, then per unit of the lung, the bacterial load would be much higher. So especially if it's a child from rural India, especially if it's a child who's malnourished, who is PEM grade 2 or grade 3, he would also be developing lung infection. Like if I'm coughing on him, he'll be getting infection in his lung, either in the middle lobe or in the lower lobe. As I said, primary TB is relatively more common in the middle and lower as compared to the apex. Then the same thing will happen. The immune system of the child will respond to this local damage. Initially, there might be lymphangitis, there would be enlarged lymph nodes. But sadly for this particular child, his immune system, because his immunity is not very good enough. As I said, he's a child from rural India. He is malnourished as well. His immunity levels are not very good. He might be a patient who's suffering from protein energy malnutrition, where you read about marasmus, kwashiorkor, and this child will suffer from manifestations of the disease. The manifestations of the disease would be that now the TB bacteria will start causing a cavitation in the lung, and there would be development of progressive primary TB. Listen to the words very carefully. Earlier I said the person, like a healthy adult like you and me, will have absolutely no problem. All that you will get in your x-ray would be a site of a calcification. All you are going to get in your chest x-ray is a calcified nodule. But contrast this with a malnourished child who was exposed to high dose of TB bacteria, that there would be a progressive primary tuberculosis, and this is where the cavity formation will occur. There would first be a pneumonia that is occurring. It would be a necrotizing pneumonia. It will cause local destruction, and then there would be cavity formation developing in this lung. And over this cavity, if you auscultate, you might be hearing that classical auscultatory finding. Like you're aware that in pneumonia we hear bronchial breathing or tubular breathing. Here what you're going to be reading or hearing is called as amphoric breathing. Then apart from cavity, there can be a possibility that because the focus is near the pleura, because the focus is in the periphery of the lung near the pleura, so there can be reactive changes, and therefore pleural effusion can develop. Pleural effusion can be seen both in primary as well as in post-primary tuberculosis. At the moment, what we're discussing is a broad topic of primary TB. Some people will have absolutely no issues. Calcification will occur, only calcified nodules will be present, but especially if person's immunity is low or he's like a malnourished child, then these bad complications can occur in the form of a cavity or pleural effusion. As the lymph nodes will become bigger and bigger in size, the hilar lymph nodes in this child are becoming bigger. I'll show you the x-ray for the same as well. These lymph nodes could be then pressing on the airways. Because of the pressure on the airways, there can be two possibilities. One, if there is a complete obstruction of the airway, then air will not be able to go inside, so there would be a distal collapse of the lung segment that would be occurring, and distal collapse will cause the trachea to be pulled to the same side. However, in some cases, there might be a partial compression of the airways, and partial compression of the airways will cause a ball valve effect. Meaning of the word ball valve effect would be that air will be able to go inside but will not be able to come outside. So air will keep on going inside a particular segment. It could result in development of a segmental or a lobar hyperinflation. I'll repeat that fact once again. I said if it is complete compression, extrinsic compression of the airway by an enlarged lymph node, agar pura airway dab gaya, then to air will not be able to go inside, so collapse. On the other hand, if it's a partial collapse, then what's going to happen is ball valve effect will come in. That is, air will be able to go inside but will not be able to come outside. And if the air is not able to come outside, there would be a segmental or a lobar hyperinflation described. Over and above this, local damages to large airways can be seen, so it can result in development of bronchiectasis. And usually we read a term bronchiectasis sicca. Bronchiectasis sicca as a term, if you go through the respiratory section in bronchiectasis video, I've said it separately and I'm saying it here also. Every time you read the term bronchiectasis sicca, you first think that sicca basically means dry. I mean, traditionally bronchiectasis would be having foul spelling, purulent sputum that increases in amount with postural drainage. But here, when you read dry bronchiectasis, that is a feature that is seen with tuberculosis, and in some cases there can be occult hematogenous dissemination. This is the worst case scenario for any case, because if there is a hematogenous dissemination, it can spread anywhere. It can spread to the meninges, so this child can develop tubercle meningitis. It can spread to both the lungs. It can cause a biliary tuberculosis. It can spread to adrenal glands. Then it can result in development of Addison disease. So if there is a hematogenous dissemination, it can even be genitourinary. It can be port spine involvement. So this hematogenous dissemination is like a worst case scenario that is occurring, and this would result in dissemination, and this would result in development of miliary tuberculosis in this patient. So that would be description for what is going to happen in case a person has a poor immunity. That is just to simplify things. If you have good immunity, never a problem. Don't think that it is child who's only going to suffer from this. This can happen in adult also. Why I mentioned a child is mainly to sensitize you to the fact that per se, you see, child will be exposed to higher, load of TB bacteria per unit of lung volume. Adult coughing on adult, lung volumes are relatively bigger. Adult coughing on child, the unit per lung, the bacterial load would be relatively per lung volume, it would be relatively higher, which is why extensive damage has been described here. But the denominator here, the most important one, is the ability of the immune system to react. So how your body reacts to tuberculosis could be either of the two manifestations. I mean, some people in their internship would be exposed to TB, and if I get your X-ray done 1 year after your internship is completed, you all will be having calcified nodules. That is what happens in majority of healthcare workers. Some who are relatively unlucky can develop this, or if it's like a child or a manifestation that I told from the community, then these are the manifestations that would be occurring. And we'll next focus on the X-ray images, which we need to remember. Focusing on the first image, the question mentioned history of fever that was low grade, evening rise of temperature, weight loss, night sweats present in the case, and the X-ray is showing this ill-defined opacity on one particular side. Considering that it is a short history of suggestive of infection and there is a hilar lymphadenopathy, so I will consider this to be a infection suggestive of tuberculosis, and then subsequent workup of this patient needs to be done. But in the second X-ray, you can notice multiple white spots that are present. So that would be referred to as a miliary picture. And this miliary picture is also referred to as a snowstorm appearance. The reason for this miliary picture can be one, obviously the occult dissemination that is occurring into the lungs itself via the blood vessels of the lung. I mean, it's spreading by the lymph node into blood vessels, and from the blood vessels, then it is disseminating into both the lungs via the pulmonary artery. That would be miliary tuberculosis. But even the commonest occupational lung disease in India, silicosis, can be associated with it. Then we have a disease called as pulmonary alveolar proteinosis, chickenpox pneumonia, even hemosiderosis seen with GPS could be responsible for this miliary picture. But these are like two very classical X-rays that we see with respect to tuberculosis. One where there's a hilar lymphadenopathy, and in the second one, there has been a hematogenous dissemination producing a snowstorm appearance. We will now come to the most awaited one, that is post-primary tuberculosis. This is also called as adult tuberculosis, or is also called as secondary TB or reactivation. So let me just create the groundwork for you. I had said that I was exposed to tuberculosis in my internship, but subsequently I did not suffer from TB because there was a calcification around the initial focus as well as around the lymph nodes. But subsequently, there is a possibility, though it did not happen in me, it can happen that the TB bacteria can escape from this prison wall. You can see the purple is the representation here for the calcification, and the TB bacteria can exhibit a reactivation, and because of this reactivation, it can disseminate from here and can go to the apex. What I'm teaching you at the moment is called as reactivation of tuberculosis. See, TB bacteria can remain inside this local prison wall for as long as 5 years. It can survive inside the giant cells for as long as 5 years, thanks to that product, that virulence factor that I was teaching, lipoarabinoman. Because that lipoarabinomannan gives that ability to this bacteria to survive for so many years. So in next 5 years after I got exposed to TB, though I did not suffer, had my immunity become lesser, then this TB bacteria could have spread. Majority of cases of adult tuberculosis is reactivation of tuberculosis, which is referred to as a post-primary TB, which means that they were exposed to TB a couple of years ago, a couple of months ago. But at that point of time when they were exposed to TB, they did not have any symptoms. Rather, the body reacted and controlled the infection. There was a containment that occurred. But from that containment zone that was created, then the bacteria are showing a dissemination out towards the apex, because that is where the higher concentration of oxygen is present. So most of the time we find is reactivation occurring in the apical part of the lung. So apex is the one which is usually involved. In some MCQs, he may not write apex for obvious reasons. So your answer would be given as upper lobe, and it would be technically answered as posterior segments of the upper lobe. I'll repeat my data once again. For secondary tuberculosis, this person was exposed to TB couple of weeks or months ago. He did not have any manifestations of TB at that point of time. But subsequently, his immunity became less. Maybe he had a bad typhoid, which took a couple of while to recover. And because of that, because his immunity was on the lower side, the disease showed a dissemination, and the infection can go supraclavicularly or it can be going infraclavicularly. If the infection will be going supraclavicularly, then it is classically called as Puhl's lesion. Whereas if it will go infraclavicularly, we cannot predict where it will go. It can go to both the areas, but the supraclavicular involvement is called as Puhl's lesion, and the infraclavicular one is called as a Asman focus. Remember, infraclavicular, IC means infraclavicular, that is Asman focus. The supraclavicular is the Puhl's lesion. And what is happening here is that there is a development of local, first there would be a pneumonia, and then there will be local destruction that will result in development of a cavity, and this cavity will start becoming bigger, bigger, bigger. Let us assume this is a bronchus and there is a cavity near it. So the cavity will keep on becoming bigger, 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 and one day the cavity will become so big that it will start communicating. Like if I just modify this diagram, I said there was a cavity that was present here previously, and now the cavity will become bigger, bigger, bigger. It will cause local destruction and it will communicate with the bronchus. Now all the bacteria which are present in the cavity will be thrown into the sputum of this patient, and this guy will turn sputum for acid fast bacteria positive. You can also see from this representation that if the cavity is small, the bacterial load will also be smaller. So therefore, there is a possibility that the person will be sputum for acid fast bacteria negative if there is a small cavity. On the other hand, if the cavity will be relatively bigger in size, then the person will be sputum for acid fast bacteria positive. Sputum for acid fast bacteria negative does not mean that it does not have TB. Sputum for acid fast bacteria negative does not mean, the smear negative does not mean it does not have TB. It means he has a small cavity because the bacterial load is less. That is why smear is turning out to be negative. But if it's going to be a large cavity with a high bacterial load, so the smear will turn out to be positive, and surrounding this cavity would be blood vessels as well, and that is when even hemoptysis as a manifestation can occur. So the main message at the moment is that because there is a local lung destruction occurring at this point of time, this guy is going to suffer. There's going to be fever present. There's going to be cough. Anybody in India having fever and cough for duration more than 2 weeks, we have to suspect possibility of tuberculosis. There will be a substantial amount of weight loss. The appetite of this guy will start becoming lesser. We will notice that classical evening rise of temperature being documented by the patient. Night sweats also documented. And then the worst case scenario can be damage to blood vessels, which can result in even a hemoptysis. In some cases, it will be non-life threatening. In some cases, it can be a life-threatening hemoptysis as well. So a question from respiratory system: what is the leading cause of massive hemoptysis? Though leading cause of hemoptysis can be a viral bronchitis also. It can be viral bronchitis as a leading cause of hemoptysis, but massive hemoptysis is mainly because of TB, and he will ask you the source also. And the source of massive hemoptysis in TB would be answered as bronchial artery. Because it is bronchial artery, that is why it would be life-threatening. The amount of massive, when would you say massive hemoptysis? Then it would be something in the range of about 600 ml of blood in a 24-hour period, or he says a single episode more than 150 ml. There are two definitions. One is that the blood in the sputum that is coming 24-hour period is 600 ml or more. Second is in a single episode it is more than 150 ml. The source of bleeding in this case would be bronchial artery, and because it is life-threatening, he will ask you treatment of. This is again a very important MCQ. What is the treatment or choice for massive hemoptysis? Your answer would be given as bronchial artery embolization. That bay word is not for what you're thinking. The bay here is bronchial artery embolization that I have described. Plus, when you are going to auscultate over this cavity, you will be able to hear the classical auscultatory finding. Like in pneumonia, I've told you that the reliable auscultatory finding for diagnosis of pneumonia is bronchial breathing, not crepitations or rales. Similarly here, amphoric breathing, the metallic character to the sound would be present. Amphoric breathing, where you get a metallic character to the breath of the person, would be seen with respect to a lung cavity. Along with this, subsequently, Even if we treat this guy, the cavity will begin to collapse, but in the later part of the disease, we do find sometimes that these cavities can get infected with aspergilloma, and that is again bad news because they are again angioinvasive and damage could be occurring. Additional fact which I would like to mention at this point of time is, like, let's take this representation of bronchial artery and this as a representation of pulmonary artery. So you can just stop noting for a while and just listen to the words I say. Like, I have shown bronchial artery and I've shown pulmonary artery here. uh, Bronchial artery I've shown relatively less connective tissue. So in a relative sense, I want to say that if there is a local destructive process, endarteritis, this artery will get eroded, branches of it is getting eroded, so hemoptysis can be explained. But then we also see that there is a possibility of uh, the TB bacteria damaging the pulmonary artery as well. But most of the time with respect to pulmonary artery, we find that because it has more connective tissue, so there is a chance of formation of an aneurysm. And what I've tried to show before you is a question of the previous years where the question said that Rasmussen's aneurysm is found in. I mean, he asked the blood vessel. Obviously, Rasmussen's aneurysm is present in TB. That's okay, pulmonary TB. But then the question said Rasmussen's aneurysm will involve which blood vessel? Then the answer should be given as pulmonary artery. I repeat that once again, that aneurysm formation can occur with respect to both the blood vessels. But on a prevalence perspective, you need to remember Rasmussen's aneurysm is seen with respect to pulmonary artery, and this could result in development of the aneurysm can sometimes rupture as well. So even that could be explaining reason for development of hemoptysis in these patients. There are two details to be remembered for Rasmussen's aneurysm. One, I said it has tendency to mainly involve the pulmonary artery. Second to be remembered is that if he says there is a rupture of a dilated vessel in a cavity. You see, bronchial arteries are around the cavity. If there is a rupture of a dilated vessel, look at the word dilated vessel means there is already an aneurysm, no? So he put up a trick question in the exam that there is a rupture of a dilated blood vessel in a cavity of a case of tuberculosis and which blood vessel is involved. And guys casually answered it as bronchial artery. For bronchial artery, I said less connective tissue, no aneurysm formation, no dilatation, it will simply pop off. But because he mentioned this word dilated blood vessel, had this dilated word not given in a question, then answer would have been bronchial artery only. The question said rupture of a dilated vessel in a cavity. Because he's saying the word dilated vessel, it means that there is an aneurysm in the blood vessel that is in the pulmonary artery, and that is why Rasmussen's aneurysm, that is pulmonary artery as a source, will be given. But if I remove the word dilated, then bronchial artery would have been answered. Another fact that I would like to mention is that in some cases of TB, clubbing has been documented, though it is a very rare finding. But traditionally, we read about clubbing with lung cancer. But in literature of tuberculosis and Harrison, clubbing has been mentioned even with respect to pulmonary TB as well. Plus, as I've already sensitized you, aspergilloma can be developing in a old cavity. Next, I'll focus on some classical foci name, like I was mentioning regarding Gaunt's focus. So he can ask about pulmonary vein focus as well. The name to be remembered is Wiegert's focus. This is taught in pathology as well, so should be a good repetition. For brain, it would be a Rich focus. For liver, it is Simon's focus. I've taught about Simon's disease in endocrinology, but now I'm teaching you about Simon's focus for the liver, and then would be lung focus. That would be Simon's focus. You see, earlier part I was talking about Puhol's lesion in the lung and Assman focus or secondary tuberculosis. Simon focus will be having a calcification around it, so it's an inactive focus. But these are some classical foci name with respect to pulmonary tuberculosis, which have been asked in the yesteryears, not in these last 3 to 4 years, but in the previous year questions, these classical names have been given. These classical names have been removed from the current edition of Harrison, but still because of the traditional data, the details for the same has been mentioned. Next up is workup of tuberculosis, and we'll first look at the case definition of meaning of the word presumptive tuberculosis. That would mean that anybody having cough for a duration more than 2 weeks, and along with this, there could be a couple of other symptoms as well. The symptoms could be ranging in the form of low-grade fever, evening rise of temperature, weight loss, and then even possibility of hemoptysis, which I mentioned earlier. Now, considering that we have to do a workup, there are two ways. One, I'll be taking care of the sputum smear of the patient. There would be total 2 samples that would be taken. One would be supervised, one would be unsupervised sample. And second we can be doing is a chest x-ray. Now, based on the smear report and the x-ray, there can be 4 permutation combinations that can be made, and I'll just gonna make them hypothetically. S plus here means that the sputum smear is turning out to be positive. It could be both the samples being positive or at least one of the two being turning out to be positive. and then would be a positive chest x-ray, and at the other end of the spectrum would be where the sputum is turning out to be negative, the sputum smear, and the x-ray is either not available, so I've written NA means not available due to lack of resources, or chest x-ray report is turning out to be negative. Let's create the remaining two permutation combinations as well, that is smear positive but x-ray report is turning out to be negative, vice versa, smear is negative but on the other hand the chest x-ray is turning out to be suggestive of possibility of a lesion of tuberculosis. Now let's look at the first box that I've created where both the parameters are positive. As you can see from the line diagram, this means that we are dealing with a case of microbiologically confirmed tuberculosis. Most of the time, the question that would be asked to you in the exam, however, would be the third entry that I am currently focusing on at this moment, where it'll say that the smear is turning out to be negative. If smear is negative, I cannot say microbiologically confirmed, though X-ray is suggestive of possibility of a lesion with respect to tuberculosis. So he will say what is the next best test that you would be writing for this patient, and you will say that on the sputum sample we'll be doing a CBNAT, that is cartridge-based nucleic acid amplification technology. So this is one of the common aspects that you need to remember, that if the smear turns out to be negative but X-ray is suggestive of a possibility of TB, then the next test to be done is CBNAT. Now we have another very interesting data lined up. Suppose the sputum report is positive, but at the same time the X-ray is turning out to be negative. He says, then how are you going to proceed subsequently? So when you check out the actual NT-EP flow chart, you will notice that if sputum is positive, X-ray is negative, what we are going to do in the patient is again proceed in this particular fashion. I mean, that's the flow chart direction, that because sputum report is positive, we can still call it microbiologically confirmed case of tuberculosis, but there is a catch to it. The catch is that if the person is living in an area where there are high MDR settings, high MDR is defined in the textbook as more than 5% of all the samples are turning out to be positive and are exhibiting a multi-drug resistant setting, then in those circumstances, it says again perform a CBNAT. So this is the second indication for CBNAT that I've explained to you. Listen to this with an open mind. The point is, if smear is negative and X-ray is positive, understandable, we have to do a CBNAT because I want to demonstrate the presence of bacteria in the sputum of the patient. But if the sputum is already positive for Mycobacterium tuberculosis, but X-ray is negative, one possibility is X-ray is negative because lesion is very small. So one common sense thing that tells me is that if X-ray is negative, probably the lesion is small, I can be doing a HRCT. But that would be a Western concept. Availability of a CT scan may not be possible in a peripheral healthcare setting in India. So that is why this flowchart has been made, taken into consideration the practical scenarios. I mean, ideally, he says that over a period of time, CBNAT has to be done in all the suspected cases of tuberculosis or presumptive cases of TB. But this flowchart is what he has taken into consideration, considering that there could be paucity of resources as well. So if in a question he mentions sputum positive, X-ray is negative, and the patient is not in a MDR setting, then it is still a microbiological confirmed TB. But if he lives in a high MDR setting, then again CBNAT needs to be done. I've told you two indications for CBNAT at the moment. Let's revise them. If the smear is negative and X-ray is positive, I need to microbiological confirm the presence. Second possibility would be a high MDR setting in the scenario of the second box that I have mentioned. And now would be the third obvious box where we need to do a CBNAT, that is a person living with HIV, or it could be extrapulmonary TB, or if it's a child who's malnourished and he is having in his family a contact with an open case of pulmonary tuberculosis. So you can see that the data is expanding and is going towards CBNAT. There are three basic investigations that I've said: sputum, smear, chest X-ray, and CBNAT that need to be done. And in a tertiary care setting where I'm having all the facilities available, I'll be doing a sputum as well as X-ray as well as CBNAT. And I mean, I'll not wait for this flowchart at tertiary care because I have all the facilities. I'll do a sputum plus X-ray plus CBNAT. If required, I'll do a HRCT in the case as well. So as such, this is just a guideline from a public health perspective that needs to be remembered for the exam. And then comes another aspect, which is the fourth box here. I'll say from the fourth box perspective, very practical, that there is a high suspicion of pulmonary tuberculosis, but at the same time, sputum smear is negative and X-ray is negative. In those circumstances, it says that again, because you are having a high suspicion, the test that you should be doing for this case is again CBNAT. So you can see the data for CBNAT has increased. It is related directly to box number 3. It is also related to box number 4, is indirectly related via box number 2 as well. And well, at the moment, if you're having any issues in understanding, You would be aware of this even from your PSM classes as well. And before I just focus on those four boxes once again, I just want to say that this ideal situation that we see in textbooks where we can see a very delineated cavity in the lung is like a far-fetched aspect. In reality, a lots of time X-rays, either facility would not be available, X-ray quality report may not be good, or for that matter of fact, a lesion like this may not be visible. So there are four boxes that I have just explained to you, and you can just see these four boxes and you can see the flow of information for these boxes. If both things are positive, he says microbiologically confirmed. If both things are negative but or not available, high clinical suspicion, again CBNAT needs to be done in this case. Then you can see CBNAT coming directly with respect to point number box number 3 as well. But then there is an indirect box which is also coming. If you just follow the marker at the moment, smear positive, but chest X-ray is not suggestive of TB. And then you can see the flow chart. He says, okay, smear is positive, suggestive of confirmed from microbiology perspective. But if he's living in a MDR setting, he retraces his steps and he again goes back in the flow chart. And you can see that when you're going back in the flow chart, you're going back once again towards CBNAT. So because of the fact that this might cause a bit of problems with retention, it's simple and straightforward. Obviously, we need to do a CBNAT, but then when would you be advising a CBNAT? And most of the time, the questions that would be asked on this would be of the next best type variety. Coming back to the original table that I had created before you, I would suggest you to make these four permutation combinations by yourself and then use a separate color pen, especially for where the CBNAT is coming up an answer. And if CBNAT cartridge-based nucleic acid amplification technology is revealing presence of Mycobacterium tuberculosis, then there can be three possibilities. One possibility is that the person is having sensitivity to rifampicin. In those cases, this would be a drug-sensitive TB and the treatment for the same can be done. At the other end of the spectrum could be a rifampicin resistance, because CBNAT can determine rifampicin resistance as well. And then we'll have to take into consideration the possibility of a multi-drug resistant TB, and the algorithm will be a different one that would be used. But he can also ask you that if the rifampicin resistance is determined to be of the indeterminate variety, then what is the next step that you would be doing in this case? And your answer in this case would be that I'll be doing a repeat CBNAT so that I can prove that, okay, this is a rifampicin which is indeterminate. On the other hand, if the report still turns out to be inconclusive, he says, what is the next test to be done? Then your answer would be LPA, that is a linear probe assay. These linear probe assays are more accurate for determining the possibility of a drug resistance, or we can do a liquid culture as well. The liquid culture will be having a Middlebrooks broth because we'll be using a Bactec system. In that Bactec system, the bacteria will be producing carbon dioxide. The carbon dioxide will react with the reagents in the liquid culture, and this will result fluorescence, and this fluorescence can be picked up by that Mycobacterium growth indicator tubes. So once we get this algorithm right, especially with respect to data for when would we be doing a CBNAT, especially the yellow arrows that I've highlighted at the moment before you are the ones which are to be focused. And then we'll next focus on another important aspect where he says that in all cases where you are working up a case of presumptive TB, he says that you should also be offering them HIV counseling because of high prevalence of HIV with TB in India. And the problem with HIV with tuberculosis would be that in a setting of HIV with TB, the cavity size will be smaller. Yes, guys, in HIV with TB, cavity is not bigger because see, cavity will always result when there is a fight between the bacteria. And in HIV with TB, the cavity size will turn out to be relatively smaller. Because the cavity size will be smaller, the bacterial load will be lesser, so the sputum smear will usually turn out to be negative as well. At the same time, because the immunity is less, the Mantoux of the patient will also turn out to be false negative. So you can see with HIV with TB, though the disease is very much present, but the conventional tests like Mantoux will turn out to be negative, smear will turn out to be negative, and cavity is small, then possibility X-ray will also be relatively normal. In HIV with tuberculosis, the problem is that the disease in the lung may be limited, but the chances of dissemination will be higher. So in a setting of HIV with TB, we will usually notice that incidence of extrapulmonary TB will be on the higher side. Plus, in the routine CNS discussion, I have said it, but I would like to, there I've written it also, but here I would like to say it verbally, that in a case of HIV with tuberculosis, if he says that what will be started first we will be starting our patient on anti-tubercular treatment, and then he'll be starting on combination antiretroviral therapy, and the gap between the two should be kept as approximately 2 weeks. The reason for that being that if you first start antiretroviral therapy, then it will upgrade the immunity, but at the same time, that will also result in worsening of symptoms of tuberculosis. That is called as IRIS, immune reconstitution inflammatory syndrome. So I would suggest you to also listen to CNS infections, where I've talked about tubercular meningitis, and I've talked about combination of HIV, TB, and the statement I'll repeat once again. Every time there is a combination of HIV with tuberculosis, and he says that what is the intervention or what is the order of algorithms that you'll be using. The algorithm that you'll be using is that first you will be giving anti-tubercular treatment, and then you will be starting the patient on antiretroviral therapy. The gap between the two will be approximately 2 weeks, and failure to do this results in development of iris. I repeated that so that the data becomes very, very clear. And the common stain that is used to stain the sputum smear preparation that you made would be a Zn stain, that is the Azil-Nielsen staining. Though we also have now LED, that is light emitting diode based fluorescent microscopy, also available. So with improvement in technology, we will be able to pick up not only drug resistance, but we'll be able to do a faster evaluation of our samples as well. As far as the various methods for detection of tuberculosis are concerned, let's just focus on each one of them one by one. For solid culture, I can be using a LJ media, that is Lowenstein-Jensen media. Now, as far as the turnaround time is concerned, for smear positive cases, the colonies will start appearing in approximately 3 weeks. But in case the smear report turns out to be negative, then before I declare the report as a negative, the duration would be much more prolonged. That would be as long as 4 to 8 weeks. So you can see that the turnaround time will be substantially increased with respect to doing a solid culture, which is the reason why we prefer nowadays doing a automated liquid culture. In automated liquid culture, we are using BACTEC. We are using Mycobacterium growth indicator tubes. This system would be called as BACTEC MGIT 960 TB. And as I explained earlier, the bacteria will produce carbon dioxide. It will react with the chemicals in the BACTEC system, and that will produce fluorescence, and therefore the diagnosis of the patient can be made. In smear positive cases with BACTEC, the diagnosis can be made in a period of about approximately 8 to 10 days. And if it is a smear negative case, then the diagnosis will be made over a duration of 2 to 6 weeks. But you can see the turnaround time has been substantially reduced. Time is essence now. We always want a fast diagnosis. So with molecular testing being preferred nowadays, one of the best molecular testing methods that is available is CBNAT, which has advantage of not only having a short turnaround time. I mean, the turnaround time for CBNAT would be only 2 hours, and it will also tell you if there is a presence of rifampicin resistance. We can also do a TrueNAT, but overall between the 3 tests that I'm mentioning, linear probe assay, CBNAT and TrueNAT, as far as the diagnostic sensitivity is concerned, the best diagnostic sensitivity would be answered for CBNAT, which is written as expert MTP RIF. The RIF would stand for the possibility of a rifampicin resistance. With a linear probe assay, the turnaround time, you don't need to remember the turnaround times. That is just to tell you that time is essence and we want a fast diagnosis. So with a CBNAT, like in 2 hours, I'm knowing that, okay, I'm dealing with a case of, Mycobacterium tuberculosis is detected in whichever sample that we have processed, and at the same time, there is an incidence of rifampicin resistance. And nowadays, we also have rapid TB identification tests on a solid or a liquid culture growth. And in this particular scenario, the turnaround time is going to be shocking 15 minutes. Yes, guys, as little as 15 minutes. So with respect to immunochromatographic assay, the diagnosis or the turnaround time for making a diagnosis from the microbiological perspective would be a short period of as early as 15 minutes. So we are trying to improvise and reduce the diagnostic waiting time per se, or the bacteriological confirmation times are significantly getting reduced. Overall, if they select which test should be done for detecting rifampicin resistance and initial detection, your standard answer is NAAT, that is nucleic acid amplification technology / PCR. And suppose in the question LPA, TrueNAT, CBNAT all are given, then as I explained, the sensitivity perspective, CBNAT should be answered as first. The turnaround time with the CBNAT would be 2 hours. With rapid TB identification and immunochromatographic assay, it would be 15 minutes. And as far as BACTEC system is concerned, I said Mycobacterium growth indicator tubes, he can ask you that what would be present in this liquid media. Then you see, you read multiple such data with respect to microbiology. So he can incorporate a bit of data from the microbiological perspective. That would be Middlebrook broth. So traditionally we read about like LJ media with dorsal egg media, and now I'm focusing on Middlebrook media as well, or Middlebrook broth for identification in the Mycobacterium growth indicator tube. Once we've done that, we'll next focus on the therapeutics and the treatment algorithms that we'll be using for drug sensitive and drug resistant tuberculosis. Now, for a case of drug-sensitive tuberculosis, the drugs that would be used first line would be isoniazid, rifampicin, pyrazinamide, and ethambutol. So let's just make it a quick recap with respect to what is the dosage of drugs that would be used. So it would be 5 milligram per kilogram for isoniazid, 10 milligram for rifampicin. Pyrazinamide is 25 milligram. Well, the rationale is why we are giving such a large amount of pyrazinamide is because pyrazinamide has a special intracellular action, and it kills those non-dividing persisters which are going to be stubbornly present inside the giant cells or in the macrophages, and thereby pyrazinamide is one of the main drugs or the weapons that you have that is causing a shortening of the total duration time to 6 months. I mean, that's the main firepower which ensures that we can complete the total duration of treatment in 6 months with an intensive phase of 2 months and a continuation phase of 4 months. The dose of ethambutol would be approximately 15. And let's now look at the mechanism of action for each of these drugs. So a quick practice of these from the microbiological perspective. Well, as far as isoniazid is concerned, what it will do is what gives a particular character, acid-fast character to the bacteria is mycolic acid. So this molecule will basically be causing an inhibition of mycolic acid synthase. In contrast, when it comes to rifampicin, this would be directly acting on RNA polymerase. So inhibition of RNA polymerase or for rifampicin is the mechanism of action. For pyrazinamide, you're aware it's a prodrug. This prodrug is converted into an active format. The name of this active format is called as pyrazinoic acid. And this pyrazinoic acid is the one which is mainly responsible for that intracellular action. I mean, this is like a specialized SWAT team that goes inside and neutralizes the bad guys. And what I mean by neutralizing the bad guys are those stubbornly surviving persisters inside. It specifically kills the non-dividing. I mean, normally TB bacteria are going to be very fast dividing. Those are the ones which are called as fast growers or are called as slow growers. But then we have those persisters as well that could be surviving inside the giant cells and macrophages for months and years altogether. Yes, guys, months and years altogether, TB bacteria can be surviving stubbornly inside the giant cells. And to kill these bad guys, that is why pyrazinamide is being used. And then is ethambutol, which has a bacteriostatic action. So he will ask you, how will it work? Your answer will be, it will inhibit the formation of the cell wall, and a product in the cell wall that it will be inhibiting is called as arabinogalactan. I repeat that again. You need to remember for isoniazid, this is again a prodrug which will act by inhibiting mycolic acid synthase. Then as far as rifampicin is concerned, it's relatively easy. RNA polymerase, pyrazinamide, prodrug again getting converted into active format, killing intracellular bacteria. And then arabinogalactan synthesis in the cell wall is the one that is inhibited. And thereby we have now remembered the mechanism of action of the 4 common drugs, the ones that are used in drug-sensitive TB. As far as the top 3 drugs are concerned, they are bactericidal. And the last drug, ethambutol, is bacteriostatic. Then comes the role of, I would say, the impact on the liver. So all of them can harm the liver, but you've done that in pharmacology also that the one which is the most hepatotoxic antitubercular drug would be not isoniazid or rifampicin. The most toxic hepatotoxic antitubercular drug would be answered as pyrazinamide, and then ethambutol does not cause hepatotoxicity. Ethambutol rather has that peculiar side effect of contributing to optic neuritis. And from the perspective of metabolism, I can say the top 3 drugs, that is isoniazid, rifampicin, pyrazinamide, they're metabolized by the liver, and ethambutol is metabolized by the kidney. And now we come to the vexing problem of drug resistance. So we need to remember the genes which are responsible for isoniazid. The main gene that is responsible for drug resistance is CAT-G. I mean that Katrina wala G. And then another one that is INHA. First answer would be CAT-G. That would be gene responsible for causing a drug resistance. Then for rifampicin, it's relatively easy. The alphabet R being used, that is RPOB gene. For pyrazinamide, it is PINKA, that Priyanka Chopra wala PINKA. So CAT-G2 actress is named here. And then for ethambutol, it would be EMB. So overall, I can say that rifampicin and ethambutol, it's still relatively, the alphabets help us remember RPOB and EMBB. And that is the reason that he is not asked for rifampicin or ethambutol, but he's asked for genes responsible for resistance for isoniazid. That would be CAT-G and PINKA. And then for streptomycin, nowadays injectables are not recommended, as you're aware from the update in NTP that came in 2021. But still, streptomycin, the gene involved would be by the name of RRS. Traditionally, we read RRR movie, that RRS gene. And then for fluoroquinolones, you're aware that how do fluoroquinolones act? They act by inhibiting DNA gyrase. So you need to remember two genes that would be called as GYRA and GYRB. And that would be a quick one-page summary with respect to the common first-line drugs that we'll be using. And as far as the intensive phase is concerned, it would be a total of 4 drugs: isoniazid, rifampicin, paracetamol in 2 months. That would be 56 dosages. For continuation phase, it would be 3 drugs, 4 HRE, that would be 112 dosages. And we need to add pyridoxine because of the side effect of isoniazid, which results in development of, the objective is to neutralize this isoniazid side effect of peripheral neuritis, which is why we are giving pyridoxine. But if you give too much of pyridoxine, then again B6 toxicity can again result in development of peripheral neuritis. So that's a very common question that you're aware of, and I don't think so nowadays they'll ask such easy questions like B6 toxicity leads to. The answer is peripheral neuritis. Then is the total duration of treatment for CNS tuberculosis. In a case of CNS TB, we'll be giving total treatment for approximately a year. So it would be 2 HRZD. The intensive phase duration would remain the same, but we would like to increase the total duration of the continuation phase, and therefore the total treatment would be turning out to be 12 months. Now, here I would like to say that this is as far as the NTP is concerned. In the older guidelines, the duration for extrapulmonary TB and pulmonary TB was same, that is 6 months. But then in the NTP, he has again modified this, and this I'll say, like, I would suggest you to answer this from the current data that I'm mentioning, that CNS tuberculosis would be 12 months, and along with this, we'll be using steroids. For steroids, again, there is a slight controversy in a sense that he has mentioned the usage of steroids for both tubercular meningitis as well as pericardial TB. But in Harrison, he has mentioned that in pericardial tuberculosis, there is no role with respect to usage of steroids. He has mentioned 3 clinical studies in Harrison saying that there is no role of steroids. So a bit of flip-flop data, but the final summary is, that is what you need to remember is the data for CNS TB. Answer it as 12 months with usage of steroids. The duration of steroids would be 6 to 8 weeks. The steroids obviously need to be tapered. And then as far as steroids are concerned, we can use them in intraocular tuberculosis as well, but that would be topical steroids. So intraocular tuberculosis, if it is present, if there is a uveitis component present, then topical steroids are the ones which are recommended. And as far as intraocular TB is concerned, the total duration of treatment is 9 months. So this is data from NTP once again. A bit of flip-flop I am saying from the older data that you have read. This is the final summary that you need to answer. For CNS tuberculosis, it would be 1 year. And for intraocular tuberculosis, that would be 9 months. And along with this, we'll be also using topical steroids. Next, we'll focus on a question that was asked in the recent ANICET exam, where he mentioned that a patient on ATT has presented to you with the uric acid value of up to 10 milligram. Outrageously high uric acid was given due to pyrazinamide, and he said that what is going to be the intervention or the management plan that you'll be using. So your answer will depend upon whether the patient is symptomatic or asymptomatic. That is, if he's symptomatic, he should be having joint pain, or he should be having uric acid deposition in the subcutaneous tissues. So if the person is given to be asymptomatic, then we will continue with pyrazinamide. The logic or the rationale is that there is no point of stopping the drug. Primarily, you are losing out on the firepower. Pyrazinamide is one of the main drugs that has an intracellular action. It is responsible for shortening the duration of treatment. And if I discontinue it, I lose that advantage of or the edge that I had of my firepower over the TB bacteria, which was causing the duration of treatment to be limited to 6 months. But if the person is symptomatic, then I do not have an option, and I will have to discontinue pyrazinamide, and then the decision to restart will depend upon the subsequent clinical profile. But I have to discontinue because there would be podologia developing in the case. So the answer will depend upon whether the patient is symptomatic or asymptomatic. In the exam, he had mentioned regarding swelling in the joints. He did not specify which joints, but he did mention pain in the joints, swelling and tenderness in the joints. What is the next best course of action? The answer would be to discontinue pyrazinamide. However, a couple of students said that in their exam, in their paper the patient did not have any symptoms. It could have been oversight, or yeah, they can tweak the same question in the software. It gives them a possibility to tweak the same question in a different way. So two different candidates will be asked the same concept, but the options would be jumbled in a fashion that one candidate could be asked about asymptomatic, other one could be asked with respect to symptomatic hyperuricemia, which is common side effect seen with pyrazinamide. Ethambutol usually results in development of optic neuritis and is metabolized by the kidney. Then comes an update with respect to extensive drug resistant TB. For MDR TB, the definition is same, that there is a resistance present to at least two frontline drugs, that is at least two drugs, the frontline ones, that is going to be isoniazid and rifampicin. But then he's incorporated two more terminologies. One is called as a pre-XDR and the second one is called as a XDR tuberculosis. So let's look at these definitions as well. For the pre-XDR variety, he means that patient is MDR TB. But along with this, he says that the person is also exhibiting resistance to fluoroquinolones. The common fluoroquinolones that we'll be using is like respiratory fluoroquinolones like levofloxacin or moxifloxacin. So if a person is having MDR-TB that is resistant to 2 plus is having resistant to fluoroquinolones, then it is pre-XDR tuberculosis. Well, what is XDR-TB? The person should be having MDR-TB resistant to fluoroquinolones plus presence of resistance to at least any one of category A drugs or group A drugs. So I'll just describe those group A drugs to you as well. You know that from PSM, I know this, what I'm saying at the moment looks like a repetition from PSM, but it will be a quick revision for us. So let's do a quick recap. MDR definition remains the same. For pre-XDR is added fluoroquinolones, and for XDR-TB earlier he was talking about resistance to any single line injectables, but now is discouraging the use of injectables. As you can understand, I mean, injections are something where the compliance part would be very poor. Toxicity part will also be much more severe, so due to sudden rise of drug levels with amica seen. As a result of it, now is focusing on usage of oral drugs, and he says resistance to any one of group A drugs. Now, what are those group A drugs? Let's just practice them. The group A drugs that you need to remember for the exam would be one, linezolid. Traditionally, we read about linezolid with respect to Staph aureus pneumonia, which is caused by vancomycin resistant Staph aureus. Then would be bedaquiline. Bedaquiline is one of the most extensively asked MCQs in the exam. How does it work? Inhibiting ATP synthase, I'll write that. But bedaquiline, one of the common side effects can be remembered from alphabet Q. It can cause a prolongation of QTC interval, and prolongation of QTC interval can cause development of Torsades pointus or polymorphic ventricular tachycardia. So as far as group A drugs are concerned, it would be linezolid, bedaquiline or levoflox. Then as far as group B drugs are concerned, there would be two drugs which are beginning with alphabet C, that is cycloserine, and second would be one that is used even in management of leprosy, that is clofazimine. Clofazimine can contribute to a reddish to brownish black discoloration of the skin. Remember, reddish discoloration of tears / instead of red, it can be brown to black as well or brownish as well. So reddish to brownish black discoloration of the skin is a possibility with clofazimine. Orange discoloration of the urine is seen with rifampicin, that is okay, but reddish to brownish black discoloration of the urine or of the skin can be seen with clofazimine, that we used in management of leprosy as well. And then is group C drugs as well. So the group D drugs that C drugs that we need to remember would be dilamanid, then would be meropenem. Instead of meropenem, we can also have meropenem. Traditionally, we read with pseudomonas, no, especially if it's gonna be again multi-drug resistant. But instead of meropenem, in the textbook, he will also mention regarding imipenem with cilastatin. Additional drug. I'm not writing imipenem with cilastatin because I've written melopenem in him. So either of the two drugs can be used. And then would be PAS. Then would be ethionamide, and among the first line drugs that I have mentioned but are a part of group C drugs are ethambutol and pyrazinamide as well. So let's do a quick recap. Group A is bedaquiline, then would be two drugs beginning with alphabet L, linezolid and levofloxacin. Group B would be two of them that begin with alphabet C, that would be cycloserine and clofazimine. For C, it would be dilamanid. Then instead of dilamanid, it can be pletomanid as well. Then instead of meropenem, it could be written as imipenem and cilostatin. Then is PAS, then is ethionamide, and then the first line drugs ethambutol and pyrazinamide are also taken to be a part of group C drugs. Well, when would we be using these group C drugs when group A and B cannot be used, especially in cases of extensively drug-resistant TB? So I'll be mentioning the algorithms on the subsequent slide, but this slide basically focuses on an update that came in 2021, has been present for past almost 2.5 years, and this was a change in definition where he was first focusing on injectables, but now the usage of injectables is discouraged primarily because of the toxicity component and non-compliance. We will now focus on treatment for multi-drug resistant tuberculosis. There are two ways to handle it. One would be a shorter oral regimen, and second is the longer regimen. For the shorter regimen, the duration would be in the range of about 9 to 11 months. As far as the intensive phase is concerned, the duration is in the range of 4 to 6 months, and as far as continuation phase is concerned, that would be 5 months. And in the intensive phase, the drugs that we are using, we are going to use a mnemonic here, that is Bay loves eating cheesy pizza. Oh gosh, I hate using mnemonics, but anyway, I have to incorporate this corny, cheesy mnemonic at the moment. So traditionally, Bay is BAE, but here I am using the Gen Z generation uses words. So it's Bay loves eating cheesy pizza. So in the incubation, in the intensive phase, let's focus on the drugs that would be used. So alphabet B would be for bedaquiline. As I've explained to you already, that one of the side effects with bedaquiline, the toxicity part, can be predisposition to development of cardiac arrhythmias. Then the second drug that would be used here is alphabet E, that is ethionamide. One of the common side effects that is asked in the exam for ethionamide would be hypothyroidism. I'll mention the side effects in a while. That remember the data and keep revising your pharmacology as well. And then is I would be isoniazid. I'm putting alphabet H here to say, or let me just write it completely. That would be high dose of isoniazid that is being used here. Then it will become relatively easy after Bay. That's going to be levofloxacin. Then E is for ethambutol. Remember, ethambutol was again a part of the group C drugs that I was describing before. Then C would be for clofazimine. Clofazimine is the molecule that can cause a red discoloration of urine, red discoloration of tears. Instead of red, it can be brownish black as well. And then the cheesy pizza, the P would be for pyrazinamide. So let's do a quick recap. The Bay loves eating cheesy pizza. That is going to be bedaquiline, ethionamide, isoniazid, then levofloxacin, ethambutol, clofazimine, and pyrazinamide. You just need to select the first few alphabets, first alphabet of each of the drugs that I've mentioned. This would be the management in the intensive phase. And then what will be done in the continuation phase? Well, the Bay is going to leave, because the Bay was, maybe turning out to be too expensive. So the Bay left, and now you're left with eating cheesy pizza alone. So as such, for the continuation phase, this would be the drugs that would be used, like the guys now, or whosoever is the individual person, let's be gender neutral here at the moment. The other partner, so-called as Bay, has left, and now it's only levofloxacin and ethambutol and clofazimine and pyrazinamide that would be used, and the Bay part is now out of the picture. That is history. And now we'll focus on the longer regimen. At this moment, a query that I also get from a lot of students is that, sir, when will we be using a shorter regimen and how will we decide to use a longer regimen? Then I can say the fact that shorter regimens are the ones which are recommended for those cases which can be managed on OPD basis. That is, there is no disseminated tuberculosis. I mean, we are talking about no possibility of disseminated tuberculosis, because if it's going to be miliary TB, then it's recommended to go in for a longer regimen. Similarly, there should be no CNS tuberculosis or meningeal signs present. There should be no pregnancy present. And more importantly, there should be a documented susceptibility confirmed. In fact, it says one of the inclusion criteria for starting shorter oral regimen for 9 months would be a confirmed fluoroquinolone sensitivity. So these are the statements that you would have to remember: confirmed fluoroquinolone sensitivity, and then a couple of no's there. That would be no pregnancy, no serious disease. If it's going to be serious disease, it is longer duration that is recommended. For longer duration, it would be 18 to 20 months of treatment. So that's going to be, a lot of toxicity present in the life of this person. And what drugs would be used in this case? Then we'll be using a total of 5. That is, total would be the first 3 that would be used would be all of group A. I mean, the definition is all of group A and at least one of group B. Ideally, he says at least. I'll write it both, ideal and at least. For at least, he says that at least one from group B should be used. What I mean by group B is those drugs beginning with alphabet C, that is clofazimine and cycloserine. And ideally, he says that both in the group B, I'll repeat the data once again. The data is like this. There can be a bit of confusion remembering it. For group A, there is never an issue. Group A is all three to be used. He says that from in Harrison, it is written at least one of group B. And when you will read the data in PSM, you will be noticing that he says ideally at least two of group B ideally should also be used. So that would be three drugs in group A and two drugs in group B. That makes it five. The toxicity part would be very severe. So if there is toxicity that is not being handled, then at least four of these can be used. And then when would you be using group C that I was describing? In group C, the drugs, if you remember, were like dilamanid and or pretomanid, imipenem, cilostatin, instead of that meropenem. So group C drugs are to be used in case group A and group B cannot be used. And the reason for that cannot be used is one could be a possibility of the development of resistance, and second, there could be drug toxicities as well. So group C as is like a backup for the longer regimen. The data is like this. I'll repeat once again. The shorter regimen will be for relatively less serious cases. I mean, MDR is serious problem, but the less serious one will use treatment for at least 9 to 11 months with Bay loves eating pizza. And if it's the longer regimen for much more serious cases, then we'll have to use all of group A and at least ideally two from group B. If A and B cannot be used, then group C as a treatment can be used. And then we'd also talk about the very famous BPAL, that is 9-month treatment for extensively drug-resistant tuberculosis, where we'll be using bedaquiline, pretomanid, and linezolid. For bedaquiline, they love to ask about the mechanism of action. So it acts by inhibiting ATP synthase. So the energy generation by the TB bacteria is being hit. It's like hitting, the source of energy. Nobody can survive without energy, so the TB bacteria will die. Then as far as pretomanid is concerned, alphabet MA would help you. That is, it will help in inhibition of mycolic acid synthesis, and therefore the cell wall of the bacteria formation is being hampered. Linezolid is the traditional antibiotic which acts by inhibiting bacterial protein synthesis. So that would be the three mechanisms of action of these drugs. And well, the fight will go on because bedaquiline contributes to toxicity in a sense that it can contribute to prolongation of the QT interval. It can predispose an individual to development of polymorphic ventricular tachycardia. And even linezolid is having a long-term basis. Linezolid can again have toxicity. So there is again a recent update that came where they're saying that you can replace linezolid with inhaled spectinamides. So that's another, these updates will keep on coming. There is no limit to that, but we can try and remember the max data that I have currently explained to you. And TB is one disease, guys, where the battle will continue because the TB bacteria per se, because of this, I would say suboptimal. I would say we are paying for sins of the previous years in a sense that we were not very serious with respect to handling this disease. And then it suddenly spiraled out of control and we started having this MDR, and then we started having this extensively drug-resistant TB. So it's more of programmatic failures that the battle is still continuing. And these are the newer approaches that we have currently talked about with respect to management of case of Mycobacterium tuberculosis. So keep the pressure on, keep on learning new facts, and you will break on to the other side. Thank you so much. I knew it took a little time to cover this topic, but is an important one. I've tried to incorporate the entire spectrum with respect to TB. TB is one topic that comes in all subjects. So the reason why it took time is because I had to cover maximum number of systems, and then I had to focus on a couple of aspects from the public health perspective as well. Thank you so much.